Welcome, everyone. My name is Kathleen Sobiak. I am part of the Monroe County Health Equity Council, and I'm also working over at the IU School of Public Health. Thank you so much for joining us tonight. I want to start off by thanking United Way of South Central Indiana for the food. Thank you very much. Really important to have dinner at one of these community events. As we begin this important conversation on access to healthcare, we take a moment to acknowledge the Miami, Delaware, Potawatomi, and Shawnee peoples on whose ancestral lands we gather today. For generations, Indigenous communities have faced challenges in accessing equitable healthcare while also holding profound knowledge of healing and wellness. On this Indigenous Peoples Day, we honor their resilience, their contributions to health and healing practices, and the wisdom they continue to share. Let us approach this discussion with respect, recognizing the need for inclusive, culturally responsive care that uplifts all communities, especially those who have historically been marginalized. Thank you.
Hello, everyone. I'm Julie Thomas, Monroe County Commissioner. Welcome to each and every one of you for being here today. The Monroe County Health Equity Council had its start as Community Voices for Health. And with a grant from the Robert Wood Johnson Foundation, we focused on how decisions are made in the community which impact our health. From public policy to health providers, we learned that creating pathways for people in the community to connect with decision makers is transformative, and it impacts more than just our health. Our focus is on empowering marginalized people in our community. When Community Voices for Health ended, we continued our work as Monroe County Health Equity Council. And just a reminder, everyone in the community is invited to join and attend and be part of our group. As we hosted conversations with the community about healthcare and health policies, there were a lot of questions and concerns raised about for healthcare providers. And so this is a unique opportunity to sit down at the table, first here in the large group, and then in our small group discussions, to speak with representatives in an informal setting. So we are very grateful for all of the providers who join us today. The information we're gathering today is going to be kept as notes, and those notes are going to go back to all of the healthcare providers and also to anyone here who attended. Thank you.
Thank you all for coming. I'm sure you've heard that already tonight, but I'd also like to thank our panelists. We have Denziel Ross with the IU Health South Central Region President, Sally, I do that all the time. I'm so sorry, and it's right here. Center Manager for HealthNet Bloomington. And then we have Lori Kelly, Health Administrator of the Monroe County Health Department. I'd also like to introduce you to our facilitator tonight and our MC, Michelle Gilchrist with the Bloomington Health Foundation. For nearly 60 years, the Bloomington Health Foundation has been actively improving access to health care. They believe in investing in community health so marginalized individuals have a chance to thrive. Some examples include Hospice House Cancer Support Community Stride Center and 988 Crisis Response Team. As a leader, Michelle is no stranger to equity. While serving in the United States Marine Corps in 1988, she became the first woman to integrate the first FSSG weaponry unit in Las Pogus, where she was awarded 2 Navy Achievement Medals. Currently, she is completing her doctorate in public health, where she is researching improvement and evaluating the effect of social determinants of health in healthcare access. So, thank you very much. I'll turn it over to you.
Thank you. Can you hear me okay? Okay, good, because I know sometimes I have a tendency to move the mic around. So if you get to a point where you can't hear me, just raise your hand. I'll make sure I project so we can hear me all the way in the back. First of all, I want to thank the MHEC, the Health Equity Council, for organizing today's event. I think that not only is it necessary, but the fact that on what would be, for some of you that work in the federal or government, a holiday, to see the community come together for a very important topic. Before I begin asking questions, posing questions to our panelists, I want to start on how we think and look at equity by taking us back a few decades ago. Before originating or migrating here to Bloomington, I spent almost 30 years in Memphis. And for those that have had the privilege of going to Memphis, you know that it has a rich history in civil rights, and mostly with Dr. King. And one of the things Dr. King, if you ever go to the Civil Rights Museum, there's a quote and a statement. And he said something along this lines: one of the most inequitable injustices is injustice in healthcare. It's inhumane, and everybody should have access to it. And so the fact that we're here, 30, 40 years, 50 years later, and still talking about health equity, it's good to look around the room and see a diverse group of people who are dedicated to having some really tough conversations so that we can start looking at how do we see policy, how do we see application, and how we apply these policies and practices in the delivery of care. And so I'm very grateful and very excited to be here with Lori with the Department of Health, Shelley with HealthNet, and then Denzel with IU Health, because this is the leadership in our community that's really driving how we obtain equitable health care. So my first question to the panelists, and I'm gonna start with Shelley. You were smiling at me. I think you were saying, call on me, call on me. But my first question to the panelists is, what are some of your greatest successes as it relates to health equity? What is it that we don't know about what your organization has done to advance and further health equity?
Well, where do I start? We are a federally qualified health center, which means that we will see anybody, whether or not they have insurance or not, no matter what their background is, regardless of their ability to pay. That's a hard thing to do, but by golly, we do it. I'm working with an organization that has been around for 55 years doing this successfully. We merged with them. We used to be Volunteers in Medicine. We merged with them in January of 2020. Does everybody remember what happened then? What a great time to start a new clinic and change things, but I'm very happy with that success. We made it through the pandemic. But what I'm so proud of is that we look at each patient as an individual, and we try to work where they are and where what their needs are. We know what they need. Many times our providers know what they need, but they may not be ready. So we need to find out what is important to them. We also do refugee physicals for the Southern Indiana community. So we have 47 different languages spoken at our community or at our center, as well as 50 plus whatever different cultures that we're trying to figure out medically. And I think we do it quite successfully. We really work very hard to have bilingual staff, and we've been very successful at that. One of the things that I am most proud of, and I know you know I'm going to talk about this because this is so near and dear to my heart. In all the years I've been working in healthcare and around healthcare, I've been worried about our homeless population within our community and the care they're getting. And I am so proud to work for an organization that listened to me and when I kept saying this is a need in our community, and they very definitely supported this. And we now have the very first medical street outreach team in the state of Indiana in our wonderful little community. And I have to say it's because everybody supported this. Everybody really cared. And so we have a nurse practitioner, and we also have a psychiatric nurse practitioner. We will have another nurse practitioner starting in December. They are out on the streets. They're in the encampments. They're in some of the shelters. We will be hiring a nurse, and we have 2 outreach workers that are helping with that. I'm so proud of this. I just can't tell you. It's been a huge success. And when I say we've saved lives, we've saved lives. I'm happy to tell you stories later if you want to hear them. I love to tell them because I just think I'm very proud of what we're doing. I can't,
I would say Shelley is being very modest because what she did not mention is this idea that was really born from an interest in really doing something about a problem that we talk about. We talk about the homeless issue, but then we look at the healthcare and healthcare access. We talk about the immigration issue, but then we look at that if you're an immigrant and you don't have a social security number, you can't really access the same kind of care. And so to recognize that these are individuals in our community that are entitled to have access to care and to care enough as a health organization or community health organization to do something about it. And so this is the kind of things that we can do together when we recognize a problem and not just see it as a problem, but also devise reasonable solutions that can lead to long-term care. As a result of that, you didn't mention about your Street Medicine Institute award. Yes, because of the level and compassion for their delivering care to a marginalized population, they were one of two in the nation to receive a Street Medicine Award from the Street Medicine Institute. So I think that merits a round of applause as well. I'm going to pick on Denzel next because Denzel is my brother. If you don't know that, we're both from Kansas City. And we were cheering on the Chiefs a few weeks ago. Yeah, with no offense to all the Indianapolis Colts fans, but we were cheering on the Chiefs. And so I'm going to pick on him because he's the newbie to the group. But one thing I really love about Denzel is that he came to Bloomington as a new CEO of a relatively large health system here in the state, but mostly here in Bloomington. But then taking a look at how do we look at that system and look at opportunities to improve health equity. And just a few minutes ago, I just was introduced to, what's her title? The chief of staff, chief of staff. And how do we bring diversity into the conversation as we start talking about how do we apply health clinical care in our healthcare hospitals and systems. So Denzel, the newbie on the block, and make a tough question. What has been in the past, 8 months, your biggest success as it relates to acquiring health equity?
Okay, can you all hear me okay? Well, good evening, everyone, and thank you so much, Michelle. Thank you for having us and the opportunity for us to kind of talk a little bit about the successes that we had, and I know we'll get into other things as well, but again, special thank you to the Commissioner and the County Commissioner and the Health Equity Council in putting this together, because I think this is a very relevant and pertinent conversation. So as I think back over some of the successes that we've had as an organization, particularly here in Monroe County, I look at sort of 3 buckets, if you will. And we look at outcomes, access, and then what we've been able to do in the community health space. And I want to delve into those 3 a little bit, just to give you a little bit of perspective when we talk about the successes we have, what that exactly means. And so I'm gonna throw you some numbers your way, so please bear with me. From an outcome perspective, some of the things, and there are a plethora of things that we could probably talk about that we've been working on, but I wanna highlight a few here. Mortality index. Essentially what that means, as you know, the longer you stay in the hospital, the higher the chances of you with infections and passing. And so it was really important for us to work around how do we get patients to that next level of care in a timely manner. Not that we're pushing it, but we're being very methodical and dedicated in what we do. And we've been able to drive that down to top decile performance. And what that means is that at a 0.40, that equates to about 154 people or lives that we've been able to get out of the hospital in a timely manner, without doing that, they would have had an increase in the probability of passing. And so we are actively saving lives and very proud of that metric. Another one is our readmission rates. We want, when we discharge you from the hospital, while we love our patients, we don't want to see you back, right? Because then that also means that we're going through and doing a whole another round of workup. We want to treat you the way that you deserve to be treated from a healthcare perspective the first time. And so we track our readmission rates. And I'm proud to say that Medicare has recognized IU Health Bloomington as one of only 2 hospitals in the state for low readmission rates. And that's a big deal. Yeah, that's a big deal. And from a country perspective, we are ranked 116th out of 4,000 plus hospitals. So again, that's something that we're actively working on to ensure that our patients who come to the hospital get the best level of care that they can get. From a primary care access standpoint, we know there's been challenges on folks within the community being able to access a physician when they need it, and that's really a big deal. Over the last couple of years, we've hired 13 new primary care providers, so we've drastically increased the access to primary care providers, which of course we know if you could do that, then we could keep you out of the emergency department, we could keep those chronic illnesses better managed, keep you well. And so again, very proud of our ability to do that. Wait times for appointments year over year has been cut in half. So you're getting to your doctor a lot faster than you were in previous years. And then as part of that, we've looked at multiple different access to care. June of this year, I believe it was, we opened a new urgent care on the west side of town. That provided another access point for patients who had non-life-threatening emergencies. That they could access that level of care. And then from a community health network, which is the third point, and then I'll hand it over, our nurse family partnership program that's in the community is ranked 6th in the nation, not in the county, not in the state, but 6th in the nation. And again, that has a lot to do with their support with breastfeeding rates, premature birth rates, and birth weights. And immunization rates as well. So how are we doing to keep the community healthy, healthier than they were in the past? And we're very proud of the work that we're doing there. Also, our WIC program, Women, Infant, and Children program, it's rated #1 in the state in Monroe, Greene, Brown, and Morgan County. So again, a whole lot of things that I could speak to, but I just wanted to point out those key points. So as we think about outcomes, we think about our primary care access and what we're doing to support the community. I think we've seen great successes over the last year or 2 that we're very proud of.
Okay, Lori, you get the last question, but I really want to pose a different little question to you because when you and I met, we were in the early stages of Health First. You were in early stages of Health First Indiana, and actually filling a role that Penny Cottle had held for quite some time. And so a year later, I want you to kind of talk to me about Health First Indiana or whatever you feel is most important in the Department of Health achieving and pursuing health equity in our community.
Thank you. So as we know, the Monroe County Health Department is here to serve all individuals in Monroe County. So we are definitely focused and striving on that. One of the greatest successes happened on August 9th of 2023 when our Monroe County commissioners signaled their commitment to making Monroe County a healthier place to live and work by opting into Health First Indiana. So Health First Indiana, this does provide additional funding to local health departments who opt in, but in exchange, it is for core public health services. So additional services that we are required to provide for every individual in Monroe County. So one of the areas that we've been able to use this additional funding is for new positions. So we have 3 new positions that are focused solely on some of those core public health services, chronic disease prevention, access and linkage to care. So while we may not be providing direct health services, as you might see in healthcare centers or hospitals, we can provide a linkage and a referral to individuals and help connect them to those services that they need. We have a new position that we just filled focused on maternal and infant health, so addressing our mortality rates around maternal and infant health in Monroe County. And we have a new position that's going to be focused on public health education and our external communications. So Health First Indiana has provided us with a really great opportunity to build upon the services that we were already providing to the community, but also then focus on new services that we were not providing before.
And in addition to that, I want to talk about the $1 million, that the difference between the Health First Indiana Award. So for those of you that may or may not know, prior to being the commissioners agreeing to be a part of Health First Indiana, and I might have these numbers wrong, so correct me, Monroe County received less than $200,000 or $250,000, I think it was, per year, and now it's like $1 million. Huge difference. So the more that we can get into our community, the more that we can put those dollars to work in the communities where we work, live, and do business. So very good, and very, very proud of the work that you guys are doing. As we kind of get in our last 15 minutes here, I'm going to pose a question to 2 of the panelists and the last question to the third. So we talk about what has worked, and I wanted to start with something positive, because when we tend to have conversations like this, we start with all the negative, and we leave with a negative perspective. But really, the end objective is for us to understand what has been done, for us to kind of ponder and consider what needs to be done, and then to finally think about what we're going to do. And so this next question, I'm going to start with Denzel, and I'm going to ask him what has been the hardest or the biggest challenge in our healthcare system.
Yeah, thank you for that. I think what has been our biggest challenge is something that we know all too well, and if anyone has access to our facility over the last year or two, you've seen that we have some challenges with wait times in the ED. We know that all too well, and we're actively working on fixing those. I would say that if you have been able, if you have had the unfortunate pleasure of making it to our emergency department here within the last couple weeks, I'm hopeful that you've seen some changes because again, we're very much aligned with our community in knowing what they want. And so it's something that's very important to us, and we're actively working on that. So while we've continued to improve access to care, especially on the primary care side, we know that we're not where we need to be, and we know that we're not always meeting the standard of which our community is expecting. And so we're very much aware of that, focused on it. We have resources and a lot of great people working towards trying to overcome some of those challenges. With access in the ED, we really talk about aborting times, the ability to get a bed after being seen in the emergency department, get a bed on one of our units in a timely manner. And so one of the things that I do want to take the opportunity to talk about is that, you know, while staffing continues to be a sore spot for us, if you will, because we all know that nationally there is a nursing and physician shortage. While we know that, and we're doing things to combat that as well, specifically in our emergency department, we do not have a staffing problem. What we really have is our ability to meet a growing need. Right? And we have a aging community. All our data points to that we have an aging community, and those people are living longer. Because of that, we've seen a lot of things come out of COVID that has created people living longer with multiple comorbidities. And so our ability to meet that growing need, we continue to work through with a physical space that we continue to challenge ourselves and innovate on how we could continue to meet that need. So that continues to be a challenge for us. I, I think what also is a challenge for us is I think we could do a better job, which is why we're very happy to be here and take the opportunity to talk about it. We could do a better job of communicating and educating our community about how to use us. You have a form that is on the table there that looks like this, which is really helpful, I think, that really dictates or helps in the decision making on where to seek care. And the utilization of our urgent cares, the increased access to our primary care office. As of 2 Saturdays ago, we just started a primary care adult Saturday clinic, so that we're able to add another day so that our patients could get access. So again, access continues to be the main challenge, the main big challenge, but there are a number of different facets to that continue to be a challenge there. On the staffing front, while there are some staffing challenges on the inpatient side, I think we've done a lot of great work from a process perspective that we've been able to cut our time to get a nurse in the door from anywhere from 20 days to now 2 days. So the ability to get staff in the door, trained up to be able to care for patients, we're doing all of those things, but it's a process. We're not where we want to be, and I would like for it to go a lot faster than it's going, but we know and understand that there are a lot of other mitigating factors that add to that. The last thing I would say, though, that is not a challenge, and I want to make sure that I hit on this, is that, man, we got good people. We got an amazing team of people who are committed to our mission, which is making Indiana one of the healthiest states. And in all of the challenges that we see, one thing I could be proud about is that just about everyone who makes it into our doors continue to comment on how great the care was, once we figure out the access challenge, right? So we're well aware of that, but I'm very proud of the work that we've done in a very short space of time since I've been here, and very energized about the work that we'll continue to do to meet that need.
All right, you guys are wondering who's the second person for the question about challenges. I think this second person has to be Lori Kelly, because when you think about the Department of Health, there's some, politics and policies and things that affect what you do, as opposed to Shelley and Denzel, that they're more front and center. So talk to us about what are some of the challenges you encounter from a Department of Health perspective that we could either be of support to or that we need to be aware of as it relates to us, having a very strong and healthy and thriving Department of Health.
Sure, thank you. So I would say that similarly to one of our greatest successes with Health First Indiana and the additional funding, one of the challenges is ensuring that we have steady and reliable funding. So while we know that we have additional funding that was provided in 2024 and will be provided in 2025, 2026 is uncertain at this time, and 2026 and beyond. So it's a challenge that we are constantly having to consider and address. So while we were able to add additional positions right now, it is not yet to be seen whether those are positions that we will be able to sustain over the long haul. And those are the types of decisions that are not within my control or the Board of Health, but as a community, just operating in a governmental sector. In addition to that, grant funding. So grant funding comes and goes. So while we did receive additional funding through the state, through Health First Indiana, funding that was provided through grants with COVID and post-COVID, and grant funding that provide our harm reduction services, or STD testing services. A lot of those grant funds have gone away or they've been reduced. So it's really having to consider the landscape, all of the different changes that happen legislatively and with codes. And I would also say workforce development and sustaining a workforce that's capable and ready to respond is another challenge that we face.
On the workforce side, I think that's a challenge just for Indiana as a whole, just attracting and being able to be competitive. And so, Denzel, when you're talking about having hired 100 plus individuals, that's a kudos to IU Health. But then also on the other side, just having that challenge also on the health department side is also complex. And I know for sure with HealthNet, it took a while to really hire the right person to do the work that's needed in our community for the street medicine program. So I know you're the last person. So your question, my question to you is, what is it that you wish we understood and knew about HealthNet and what you do in the community and how we can either help or support that great work?
Thank you very much. I appreciate that. I think that's been one of our challenges. Starting the clinic, we had the Volunteers in Medicine clinic that had been around 12 years. Then we started this. Everybody thought it just all went away. When I always say this is the VIM clinic on steroids, we can do so much more. But then, of course, the pandemic hit, and it was very hard for us to get our information out there. So that's our challenge. But what do I want you to know? We have such a compassionate organization and caring group of people, and I have to say I tend to not let things go. And they have been very supportive, and they listen and they care because they have a heart. When patients come to us, we are pretty darn good at keeping them out of the ED. We are not entirely, but we're pretty darn good at it because we work on that relationship. We have the staff that are willing to put in that extra time. What we need now is to get that information out to the people that need it, to hear it, so that we can continue to do more of this good work. We've got the staff, we've got the compassion, we've got the support. I will say, I just have to say ditto on the grants. The Homeless Initiative Program is grant funded, and that is always a nightmare to continue to think about. How are we going to continue to do that? And those are very special people. You're not going to find every physician or every nurse practitioner that says, let me go truck through the woods in the mud, sit on a tree stump, and clean wounds. Not everybody wants to do that. My team does. They do it extremely well. And the thing I'm so proud of is that those people that are in the woods are starting to come into the clinic. And it's been years that we've been trying to keep them. They would come when there was a crisis, then they would leave. So it's that trust building that we do so incredibly well. And I'm proud of the team. I love the team. And I want to work with the community more. I want to work more with you and the hospital, because I think we can really make this community shine. We just have to communicate. And Lori and I are already working. So I could go on and on. I'm going to give the microphone back.
Always modest. So I'm going to brag on you a little bit more and just brag on everyone here at this table. Lori Kelly and Shelley both serve on a subcommittee with Bloomington Health Foundation related to mental health and addiction, and I'm grateful for your volunteering in that capacity. But even from the IU Health standpoint, I'm going to pick on Dr. Moore. I'm picking on you because you're in front of me right now. But Dr. Moore and I serve on a committee for the NAACP Health Equity Council. And even in his off time, while he's had a running the ER in our ER department, he's also volunteering his own time really to try to educate the community, try to help develop relationships in the community that's more positive, and to create an understanding in the community about what some of the challenges are. Because when we're users of the system, we only see what the problems are. We don't understand how the problem occurred. And so we want to make sure we be both vocal about the challenge, but also willing to listen, and so we can devise sound solutions. And so I'm grateful for that partnership. Missed last meeting, but I apologize. I was at a wedding. I think my daughter would have been upset if I came, but I will definitely go to the next one. So with that, that concludes our panel discussion. I want to thank Lori, Shelley, and Denzel for their time today and for all that you're doing in our community. I'm very grateful to have built these long-term relationships and look forward to helping us do even better in our community. So thank you. Okay, so I am also MC, so I get to give you a little bit of instruction on what we're going to do next. So at your tables, there are tables. You're not assigned to those tables. So we just had what we're going to call our panel discussion that we're going to lead into our small group discussion. And in your small group discussion, what we would like is for you to have intentional conversations at your tables with your facilitators and note takers. And I'm going to ask our note takers to raise their hands. And that way you'll know who they are at your table. At table one, our facilitator is going to be Jacob Odie. Is that correct? Jacob Oti? Otele. Can you raise your hand? Jacob Otele. Table 2 is going to be Julie Thomas. Table 3 is going to be Bryn Hannon. Table 4, Kathleen Sobiak. Table 5 is Lee McKinley. And I know Lee all too well, and I'm grateful for you and Marie as well. And then our table 6 facilitator is Terry Amsler as well. And then table 7, Susan Klein. So the topics for each table is the same. And I want to make sure, Ann, am I saying they're the same? They're the same. Okay. The topics at each table is the same. So you can either stay at the table that you're at, or you can move to another table. At the end of your 30-minute discussion, we're going to come back, so I would like for you to have a note taker. You have an assigned note taker, but to have someone report out to the large group on what your key theme has been, or what your key theme at your table had discussed. And then that will kind of help us to kind of start thinking a little differently about our next steps as we begin to wrap up today's conference. So you have the next 30 minutes to begin your discussion and report out. Okay. Lots and lots of great conversation. I'm sure if we had the time, you guys would be here probably another hour. But because I'm sure many of you are ready to get home, it's been a long day, and we don't want to prolong our conversation. So what we're going to do next is we're going to do a large group report out. And in the large group report out, there's a couple of things we want to make sure that we keep front and center as we do our report out. Always be respectful. We don't want to unintentionally offend when we start talking about tough conversations to have. It's the way in which we have it. And if you want to really take a positive step forward to remedy whatever the challenge or problem or observation is, the best way to do that is to be cordial and respectful. Then secondly, be as brief as possible, be as concise as possible, so therefore we can make time for the other groups who also had time and spent time to have really in-depth discussion. And I was going around tables and I was just, really kind of just chiming in, listening on what you guys were saying. So I'm really interested in hearing the report out. No particular order. I'm just going to make up a number in my head. Table 6. I don't even know where you're at. Oh, okay. Where's table 6? Ah, very good. And then lastly, come to the mic because we probably can't hear you, and so it'll be easier for us to use this mic since the other mic is not working. Does this mic work down here? I'm not really sure. Okay, I'm not sure. Oh,
So what am I saying? Hello, my name is Julie, and I'm with Table 6, and
Briefly, we talked about general topics of communication, collaboration, education, and compassion. We need more of all of that. And then a focus on language help was something that we talked about. And then we got into the problems of provider accessibility, not having enough providers, and complexities with pharmacies and health insurance. And then the idea of healthcare navigator, a person that is not a doctor, not a nurse, not a staff person, but somebody else in the community that's a healthcare navigator that can help people figure all of this out. And then there was also the idea that if HealthNet is succeeding in providing patient care, then potentially whatever their model is something that other places like IU Health should be considering.
Let me ask a question before you go. Okay, so when you talked about pharmacy, Denzel's like, oh, we did good. Okay, when you talk about pharmacy, can you espouse on that a little bit? What do you mean by pharmacy?
I think we were talking about the lack of different pharmacies, and then also the problem of going to pharmacies, and health insurance is not always accepted at all pharmacies, and why is that? That sort of thing.
Okay, understood. Very good. Thank you. And I want to kind of comment on that a little bit, because when we talk about pharmacy, there's also a challenge when you have a complex condition and you don't have the easy access to the pharmaceutical that you need. And when you're in a rural or smaller town, makes it even much more complicated. And so it's very important that we as a community look at pharmacy, because here in Bloomington, in Memphis, you have multiple options. You have Kroger, you have Walmart, you have CVS, you have Walgreens. But here in Bloomington, very limited. And so I think that's definitely top of discussion. In terms of communication, we are becoming a more diverse, not as diverse as we would like as a community, but more diverse. And we need to be respectful and mindful of the fact that everyone, primary language isn't English. And I know one guy, he spoke sign language. He said, this is my primary language. Oh, to him, that is his primary language. And so just being willing to meet them where they are. I'm saying hi to you because I just saw you, Julie. Thank you. All right, table 4, wherever that is. Table 4. You got a cheer squad. Okay.
Hi, I'm Sneha. I'm from Table 4. We talked about transportation access, clear communication between healthcare providers and the community people, and connectivity, reducing complexity around establishing appointments with healthcare providers, and establishing digital platforms, mobile units in other areas where there are no clinics, and
Mobile clinics or mobile apps?
mobile clinics more like, yeah. And establishing a connectivity on the mobile clinic. Yeah. And we talked about language barriers, skipping appointments, and the systematic barriers more like, and establishing trust and relationships and encouragement in younger populations for healthcare focus, like getting into medical schools and stuff like that.
Okay, awesome. All right.
Thank you.
No worries. Social determinants of health. That's the paraphrase. Your table talked a lot, and I can only imagine why y'all talk about social determinants. Look at Amy Meeks, social determinants of health, transportation barriers, communication barriers, mobile units. And I know I'm applauding Shelley again, because we do have a mobile unit that comes to the area, I think once a week. I'm not really sure the frequency, but even with IU, Priscilla, trying to get a mobile unit here in our area. What it does for us as a community, when you can treat some of those non-urgent care issues, keep them from having to go to the emergency room and overpopulating the emergency room, so you can get more appointments and have the care that you want. And so, yeah, we need to advocate for that. All right, table 3. Here we are, table 3.
Hello. So I'm reporting back from table 3. A lot of what we talked about were these really big issues, big national issues, things like transportation, racism, insurance laws, how difficult it is to understand these huge systems. And when we talked about, we were all facing these issues, and then we talked about how we could fix that, and it really seemed like that would be partnerships and not just between our different organizations, because I think we have a lot of that, as we talked about in our community. but partnerships and also trusting communities, trusting ourselves. We need education for the things that already exist, that our community does a really good job and people don't know about it. We need to get that out there, build trust with our communities. And then funding, that's what everyone needs, right, at the end of the day.
More money, more money. Healthcare is expensive, and the fact that we, as a society, can, and even as a community, can have, the various types of healthcare that we have, always amazes me. But it does take multiple types of health centers. You got your FQHCs, you have your actual hospital, then you have your FQHC health, community health programs. You got WIC. It takes so many programs just to provide this one small community care, and it really is very costly. Again, transportation, that keeps coming up as an issue, but how do you fix that? How do you fix that? Table one.
Yeah, so my name is Jacob Otile. I was leading the facilitation on table one, and the common theme that came up from our discussion was mainly one, lack of resources. And this can be in terms of the human capital, the money that is required to run everything. That was a very big one. And then uncoordinated care. And the example that our table kind of gave was a patient comes in and this health facility needs to access their records from a different health facility, and then this can take forever because the systems are not interlinked, and that can delay the care of most of these patients. The other aspect that also came up very highly was cultural incompetencies in our healthcare. And the example that we gave was, for example, HealthNet, that handles probably 50% of their patients that come in are really not English speakers. And then you may not have the enough resources to be able to deliver the service or the care to them in the terms they would appreciate, because maybe you don't know the languages, all the staff that are handling them don't understand their culture really, really well. And some of the solutions that we suggested was kind of things like constant training and making sure that the staff themselves are trained enough to be culturally sensitive to delivering some of this care. And finally, the other aspect kind of sort of interlinks with the cultural insensitivity or incompetency was generalized care, as opposed to making sure that the care is individualized to the needs of the person and the community that he or she comes from. So we kind of talked a lot about that as well, to making sure that we deliver these services. We need to make sure that we are addressing the needs of the person and the community that we are getting to interact with over and over again. Thank you.
Excellent. Well, one of the things, very good report. One of the things that we are working on, and I am going to applaud Amy Meek for helping lead in our URI that we're trying to develop for our community, Universal Release of Information Form, and everyone else that sits on that committee or a subcommittee, Shelley, Annie, if I'm missing someone, Julie, pretty sure I missed someone else. But it is very important for us as we start thinking about the care that we need and as we deliver care to people, that not one type of care provider is oftentimes sufficient. It may take multiple providers or multiple skills to deliver adequate care in order for us as a community to see the outcomes that we're looking for, in order for them to be as healthy as they can be, so they don't repeat back into the hospital. And so it is important for there to be integrated care, but the transmission of the information and the limitations that sometimes policies, HIPAA compliance, VAWA, ICRs, Indiana Code and Regulation, all of those play a major role in how it limits us from really being as effective and efficient in our delivery of care as possible. So our organization and others in the community, and Lori Kelly, I forgot to add you to that list too. You're on that committee too. But just being able to try to develop a resource that will help in expediting care. But then also I know the other group had talked about cultural sensitivity. You can't treat everyone the same because they're not. They weren't raised the same religion. They have different views. They are different ages. There's different cultural. There are different gender as well as what they eat, what they don't eat, what they can't eat. And so when we have an understanding, we can understand what the real problem is and not make assumptions of what we think the problem is because of our own understanding. So very good conversation, and hopefully we can see more cultural sensitivity in the delivery of care. All right, table 5. I don't know where you guys are. Oh, wait. Love it.
Thank you, thank you. Well, we had a lively group. There were more physicians at our table than I expected. Anyway, one word that comes to mind, Obamacare, for want of a better term, because of the drastic change that happened before that and after that. Patients are utilizing the system much more. Of course, our job is not done yet with that. Literacy was brought up strong, the need for navigators, transportation, basic transportation, and whose responsibility is that? Is it the individual responsibility, or is it the medical office you're visiting, or is it the emergency room? We're all trying to find solutions, but who's responsible for that? We talked about under changes, mobile care, maybe kiosks in the rural areas where people don't have access to broadband, social determinants of health. We talked about social media, finding some way for the CEO of the hospital to tell the hospital story in a way that people understand it, that they identify with your face, not just numbers, and that they actually feel like they have a relationship with our community. The last thing was, again, communication and relationships. Strong feeling that we need to have a unified electronic medical record or some platform that patients and doctors can access, whether they're in this health system, wherever, so that we're all on the same wavelength.
Absolutely. Very good, very good, very good. We're hearing a common theme, social determinant. Very good. I hear some applause over there. We're hearing a lot about social determinants of health. You know, health is more than just the problem, right? It's more than just a condition. There are contributors to those problems, and sometimes it's not related to the health disease or the health issue. And so we have to look at how do we fix, the transportation issue. Non-emergency medical could be an option, but we don't have enough in our community, non-emergency medical transportation organizations. And so, transportation is definitely problematic, and then coordination of care. All right, table 7 doesn't have anyone. Table 5. Did we already do table 5? Oh, just did 5? Oh, okay. I'm due table, what are you? That's not a 5, that's a 2. 2. Okay, table 2.
I am the note taker for table 2. My name is Julie, and I'm with the Community Justice and Mediation Center. And so I want to just recap that first question about what comes to mind when you think about accessing healthcare and why. So our table felt like it is not really accessible. Big shock, huh? We're not really where we need to be. It's expensive, it's chaotic, and it's complicated. And then when asked what changes we'd make to make healthcare more accessible, some themes were increasing coverage. And dental and eye care came up several different times, how important these two types of care are and how they need to be increased drastically, how a person can end up in a really bad situation by not having proper dental care or eye care. We also need to have a better understanding of healthcare. Some things are very confusing to people, and especially things like cost transparency. Those are things that we really need to make these things more understanding for our citizens. And then, of course, we talked about increasing capacity, and some things kept coming up. Mobile parahealth, so traveling healthcare units, that came up. And then education. How do we encourage people to go into primary care? So the one thing would be the cost of medical school for people. A lot of people don't go into it because it's so expensive and they're going to have loans, so they choose something else. But just how do we engage people, and how do we start that conversation and get more people to go into primary care. And then we talked about residencies and making it easier for people who have completed medical school in other countries like Canada or the UK to come and practice medicine. Or can people from Canada, if you have an established practice and you're able to come to the US, can you? We don't think that you're necessarily able to do that. So are there different things that we can do to rethink how we use resources and how we use healthcare providers? And then for working together to create change, our table, we want to make a difference, but we really want to know, how do we do that? So we started from that, really, how do we make a change? Do we write letters? Do we get involved in advocacy? What are the levers of power? And we really felt like we're asking those questions, so other people probably are asking those same questions, and we want to come together. How do we do that? Do we complete a health assessment? Do we get together and be more involved in the future? It's just something that we want to do, but we feel like we need additional guidance on how to actually do that and get involved. And how do we get involved in how laws are made and how legislation is changed?
Wow, I just felt like I just went to school. That was a whole lot. That was good. Very good. A whole lot. Okay. I'm very grateful for a couple of things, because if we don't start talking about the how, all we're going to have is just a bunch of questions, right? And so I think, and we'll talk here in a minute as we begin to wrap up. I'm going to give you an opportunity if you really want to, know how do you begin making change. One is, just look, the Monroe County Health Equity Council is a starting point, right? You have discussion, you identify some problems, but now you need to devise solutions, right? And you may, as a larger group and as a larger active group, be able to facilitate some legislative conversation. Of course, the legislatures are the ones that really make the final decision on the policy. And so we really need to start looking at the power of more people and more voices, because you only have just a handful of people. You're just a sound, right? But you have a lot of people complaining about the same thing and in the same area, then you can really have some action. So I will encourage you as we begin to wrap up. Okay, I did 1, 2, I did 3. I feel like I missed one. 4? Did I do 4? I did 4. I did them all. I feel good. They didn't do them in order. All right, is there a table that I forgot that I did not give you a chance to report? I think I got them all. First of all, excellent conversation. I really am encouraged, and I am grateful for your time to be able to share what the problems are. So our next steps is, today was really for us to really listen from the community, be able to hear what your perspective is, because we are using the system and we know what challenges we've encountered, and we work in some of these institutions. But now we have an opportunity. On your table is a QR code. And that QR code, when you scan it, it will take you to the Monroe County Health Equity Council if you want to sign up and be a part, be able to now begin to take action and begin to have further conversation in order for us to not just have our voices heard here, but collectively have our voices heard externally as well. And then also from a commissioner and other political representatives in our community, being able to build relationships with them, because they are our voice at a higher level. And so we want to make sure that we empower them to tell a more impactful story about what our needs are. Now, we can't do all things that we just discussed. Some things are more complex, right? Start talking about, the cost of care. That's, many ways you can reduce the cost of care, but it's going to be one of those things that is multifaceted. But what we can do in our organization and others like it, we can look at, like, man, if I am if I'm an individual and my copay is 20%, and I worked in transplants, and I need $1 million transplant, do I have $200,000? I do not, right? But we can look at opportunities of saying, how do we advocate for people that are in that position where their copay is 20%? If they need to access psychosocial, they don't have it as part of their plan. if they need to access other types of care and they can't afford even the deductible, right? How do we make it more accessible and affordable so we can have a healthier community? Those are the kind of conversations I encourage you to continue to have. Don't just attend tonight. Keep being part of the conversation. So I encourage you to use the QR code and to join the Monroe County Health Equity Council. So with that, I don't know if you want me to turn it back over to Annie, and she's going to wrap us up, but I have really enjoyed our conversation today. I will stick around if you have questions for me. If you want to just shake my hand or say hello, I would welcome it. But I am thankful for all the work that Annie, Lee, and others all have done to help our community to really intentionally seek health equity. So thank you very much for your time.
Thank you, Michelle, and thank you for being here. I have one more thing to add on your tables. There's some note cards. If you had an extra question that you didn't get asked tonight, you can go ahead and jot that down on the note card, and maybe if you leave your email address or phone number, we can have someone get back to you to get that answer to you. And then also, Michelle, you did a great job explaining what we were doing with the rest of this, what our deliverables are from this. We're going to take notes. Our notes from our small groups are going to be compiled and sent out to everybody on email if you gave us your email. Also, please visit our tablers. We have some people back here if you're looking for more information about other resources for healthcare in our community. We have different people back here who have been here all night to help give you that information. Yeah. And then I'd like to just say thank you to Michelle, to Lori, to Shelley, to Denzel for all being here and being a part of the conversation. It was really, I really enjoyed hearing the things that people had to ask and the information that you all were sharing with us as well. So we hope maybe we can do something again similar in the future, and we think that it turned out to be a valuable conversation.
So also, we will be sending out email follow-up that will have a link to a survey for a couple of questions. We'd love to get your feedback. The other thing is, most important, there's tons of pizza in the back. So everyone grab a plate, put some on your plate, and take it home with you. Take to your friends, family, spouses, children, and share, because we do not want to haul that back in my car. So thanks, everybody, for coming.